Okay, thanks everyone. I think we're right on time. There may be a little bit late, but we'd like to stay on time because we need to end on. So ECHO is not a traditional continuing medical education type program. This is for busy professionals, and we try to incorporate it into your work lives. So most of us have patient care or some other responsibility beginning at the time. Okay, so the structure of clinics, we don't need to do a roll call today. I think Shannon's kind of gone through who you might be. Presentation. I believe we only have one case today, which should allow for a significant amount of discussion. I think it's a pretty interesting case. So I will discuss it along with Jim Werner and Adam Brzezinski, who are both here with us today as well. So we'll get started. These are our disclosures. Chris Taylor is not with us today. He is overseas and won't be able to join us. You can read Adam and Siran's disclosures as well. I don't have anything to disclose with respect to this presentation. Okay, so this is the second in our series. And as I mentioned at the outset, communication is the area in which most provide assistance in caring for their patients. Anyone can look up the dose of Belviq or Saxenda. Anyone can look up the ASMBS criteria for bariatric surgery. That's not where the challenge is. It really is communicating effectively around weight. That's why I think about 6 or 7 of our sessions are going to deal with this issue, and relatively few therapy. The other emphasis in our series is on social determinants of health and psychosocial factors, how they influence one's success in trying to achieve a healthier weight. So that's why we have both Jim and Adam to comment as well. So why do I talk so much about core principles at the outset? And what are core principles? Why don't we just plunge into communication and practice and give you scripts to use, which we will do all of those things. The reason is these have been established over the last 10 years by at least 2 committees that I've had the privilege to be part of. The American Heart Association's Obesity Committee, which I was the chair of between 2013 and 2015. I keep calling myself immediate past chair, but I haven't been chair for about 4 years. So I don't think I count as a definite past chair now. And this was my emphasis. And the other committee is the National Academy of Medicine's Obesity Committee, which I also serve on, which is head on and has come up with some principles that we'll talk about later on in the series. But we talk about core principles because even if you don't remember all the things I tell you, you will probably keep these core principles in mind throughout your interactions with patients who have obesity. And you can apply them. So you may not remember the exact way to raise weight. You may not remember every single example of how motivational interviewing to your patients, but if you keep these core principles in mind, you will do very well. It's like cultural competence, for example, taking this out of this domain a little bit, is a huge important area. You may not remember everything about it, but as long as you treat everybody with respect, that's a good ground starting point for it. And that's the same thing we're going to talk about today. Okay, so the objectives are to list acceptable and unacceptable terms to be used in clinical encounters with patients with obesity, minimum 3 core principles in structuring weight management encounters, and provide 1 example of an unacceptable way of raising the issue of weight with patients. Let's go on. These are pretty straightforward. So where do these come from? So I was I guess I was chair back when this paper was published. This is 2011. And every chair of the American Heart Association's Obesity Committee has a different emphasis. So my past chair prior to that was very focused upon metabolic disturbances and vascular biology, certainly something I don't know much about, frankly. And I focused on communication, social determinants of health, primary care, efficient management of weight. And so I steered things in that direction for a while. This was our first big scientific statement under my tenure from 2011. It's called New and Emerging Weight Management Strategies for Busy Ambulatory Settings. Now, the emphasis in this rather lengthy document, which I think is 40 or 50 pages long, you don't have to read it. It's a little out of date anyway. I don't encourage you to read it actually, is upon communication. So there are other things here like, well, for example, how do I refer, who do I refer, etc. What's the 5A's paradigm, some things that we'll cover later on. But there is a significant section on how to communicate and core principles of communication, because I think this is a good starting point. So let's talk about first core principles, that is terminology. What are the preferred terms when you discuss weight with your patients? Now, there's a lot of emphasis, and I still make this mistake, and this is relatively new, and we'll talk about this when we come to the National Academy of Medicine competencies. We use person-first language, and that's not just with obesity, that's with other conditions as well. So they're not diabetics. Diabetic is not their identity. They're patients with diabetes. They're not obese people or the obese as if they're a separate population. They're patients with obesity. And that is considered to be more respectful. However, that's not necessarily the language we would use in encounters. So these are unacceptable terms. Obese in the context of an encounter, it's kind of cycled. So first of all, it was considered to be extremely pejorative and offensive back in the 1990s. Do not use this. And then in the 2000s, people said, hey, you need to be direct and address patients very honestly and say, hey, yes, you have obesity or you are an obese patient. It's shifted again. Nobody likes that term. Nobody likes to be called obese. And when I was in medical school 20 plus years ago, we would do histories and physicals, and we would report out to our attending physicians and stuff and say, oh, this is a 50-year-old obese male, for example. And that's not considered acceptable anymore. It is considered offensive. We have to be contemporary what society perceives to be acceptable. That's not acceptable. The word fatness has no place whatsoever in your encounters. Patients will use it. We have patients coming in saying that I'm too fat, but that's their right to do that, of course, and that's their preference to do that. But we should not be using that term in general. So adiposity, this is a term that I certainly do not use in front of patients. I have observed it being used by specialists in particular, not to pick on them, but so your level of adiposity is too high. It's just not understood by patients, obviously, not a term we would use. Heavy is definitely out, especially, so I have a lot of experience in the pediatric and adolescent realm. I can tell you that an adolescent girl does not want to be called heavy by any means. Very, very pejorative effect. The problem with using these terms, even if you have good intentions, is it will shut the patient down because they have heard these terms in a very negative context, not necessarily from bullies, but even from their own parents. So you'll have this mom bringing your teenage daughter in and saying, oh, she's too fat, she's too heavy. And the poor girl's been hearing this for years. And when they come to the doctor, if they hear the same thing, it reinforces that negative emotion within them. It's just not a way to establish any sort of rapport. Do not use it, basically. This is the preferred term over and over again, 10 to 15 years now. Patients prefer the term weight. It's weight management. Our weight management program is called Fit or Me for lots of reasons, but we do weight management. It's not, I mean, I will say this to Jim informally, we have an obesity clinic, et cetera, just among professionals. But generally speaking, we try to avoid those kinds of descriptors in describing patients. Why do you want to get to a healthier weight? How does your weight affect you? What would be different if you were to achieve and maintain a healthy weight? So achieve and maintain a healthy weight. That's the type of terminology that helps to establish a rapport. It's not all you have to do. But if you start to think, if you ask questions like, why do you think you're so fat? Even if the patient has used it, it doesn't set a good tone for the encounter. It's not respectful. And it can jeopardize the rest of your weight management. That's why we're starting with this particular principle. Additional core principles are really, really important. Empathy, of course, you have to be empathic. And that's something that is hard to teach because there are lots of people who still have biases against people with obesity. Lots of providers have biases. Now, how do you get past them? That's a big challenge. We'll talk about that with respect to the National Academy of Medicine core competencies. It's not just a provider issue. It's the nursing staff, it's the front desk staff. Everybody has to be on the same page, and we'll talk about that later. Shared experience is something that is a major issue that comes up all the time. It's like, it's true, a minority of healthcare professionals do struggle with obesity, but there are some who do. And it's okay in 2019 to say, this is an issue I struggle with as well. And so I do feel a little bit of what you're going through. And of course, so it's decent to say, look, I know what you're struggling with. Even if you don't have obesity yourself, you can say, look, because I know a lot of family members who have this issue, or I have friends who have this issue, or other patients, and I understand a little bit of what you're going through. That's a core principle. Always collaborative. We'll see how this works in a moment. It's never directive. So when Jim and I discuss goals and objectives with our patients, it's not, well, here's your goals. It's like, well, here's some basic goals we want you to meet. Can you tell us about your ideas about how you would do this? And let's kind of work together on it. This is probably the most important principle that often gets neglected, especially in primary care. Not just in pediatrics, but pediatrics is especially affected. And so we know, for example, that pediatricians, other pediatric providers have to do well-child visits with their patients roughly, and be very detailed. You got to counsel about bicycle helmets and safety and lead, immunizations. You have to talk about school performance and vision screening, and then there's this little check mark for nutrition and weight. And it's often thrown in there as an add-on. Oh, by the way, your son needs to eat more vegetables and exercise more because his weight is too high. Okay, that's not appropriate. Consistently, patients say, if you are going to address this issue, you have to take some time to do it. And we're going to talk about that in the coming sessions, but it really has to be, I'm concerned about your son's weight. I want you to come back so that we can discuss this issue specifically. That sends a powerful message to the patient. If it's an add-on as you're about to leave the room, it has no impact whatsoever, first of all, and it doesn't establish a good rapport with your patients. Patients want you to take time to do it. It's not something you can discuss in a minute or two. Other core principles from the 2011 document, we reviewed, I think, 3,000 papers to put that document together. It's recognition of successes. So, in Fit or Me, for example, a lot of our patients come back and they haven't lost a lot of weight or haven't ever even gained weight. But they'll say, look, I tried. I started to do some walking, or I started to have breakfast every morning. Well, that's good. You have to recognize people's successes because these are people that are struggling with issues for a very long time. So you never sound punitive in any way. Medicalization sounds like something you ought not to do, but it's actually very effective. Here's a core principle that I believe in strongly. I advocated for strongly. The cosmetic benefits of weight loss are none of our business as healthcare professionals. Never, ever, ever go there. And I think I've mentioned this, the most egregious example is a pediatric provider who said to a teenage boy, you'd be more likely to get a date to a prom if you lost weight. And you can imagine he didn't say anything. He's 15, 16 years old. He's not going to say anything to a physician. But that was highly offensive. He shuts down. That happens all the time. You would look and feel better. You'd be able to buy nicer clothes. You'll notice a big change of how you are perceived at work or at school. None of our business. It's a question of what is it that we are there for? The average age of our patient program here in Cleveland is 62 years of age. These are people who have struggled with their weight most of their lives, who have medical issues, and that is the core focus. And when you ask them, why do you want to lose weight? Of course, a lot of them want to look and feel better. They don't feel good about themselves. That's all fine. That's legitimate. But they also would tell you something like, I'm taking a lot of insulin lately, and I want to get off some of these medications, or my knees hurt, and it's getting to be unbearable. I can't get around. I'm going on vacation. I really can't get around. So keep that in mind. When you discuss weight, when you bring it up, and we'll talk about this, I believe, next week, you have to keep in mind the issue of, well, I'm concerned about your weight. It's putting you at risk for all these health problems. It's making your diabetes worse. It's making your knees worse. It's making your arthritis worse. Is this something you're concerned about as well? And would you like to work on it together? That's where you need to go, okay? If you start to talk about cosmetic benefits of weight, it's a highly sensitive issue for people. And not just, we think, oh, well, women are more sensitive, and perhaps that's true, but men are very sensitive as well. You wouldn't believe some of the things that they've been told too. If you go there, you're likely to run into trouble very, very early on, because you're likely to touch a nerve that's highly emotional, and you will not be perceived as an engaged partner in this effort. Your business is really diabetes, helping people live longer, preventing heart disease, cholesterol, sleep apnea, arthritis. Stick to those things. Reflection on recommendations. So this is a core principle, and we'll talk about this, and Jim will talk about this later on. When you make recommendations, when you give people goals, what we found in 2011 is that even though people can pick and choose the goals they want to follow or what they're going to do, but usually you have to ask them to reflect on what you've said. And sometimes that takes a little bit of time, a few days, because this is what I really think you ought to do. This is my opinion, and we can choose goals together, but if I were in your position, I might choose these particular options, but I want you to think about it. Don't make any decisions today. So patients need to reflect to overcome any sort of ambivalence that they have. So these are core principles. If you're going to remember any of those, remember the respectful language, remember to recognize small successes, and remember to medicalize the issue rather than any other social or cosmetic benefits. The rest really is something that you will naturally develop. I mean, when we talk about scripting and how to raise the issue of weight, it'll take time. And that's the same thing with reflecting on recommendations. And hopefully you all have, you're taking this course for one thing, so you're interested in the issue and you have a degree of empathy which will be beneficial to your patients. So let's talk about a case scenario. And this will be the last thing, and then we can go on to our actual case description today. We have a presenter today. So this is, I know this is a pediatric and adolescent case. The joke about me, I'm a family physician. No, I'm a pediatrician trapped in a family physician's body. Most of my career has been in pediatrics, I will be honest with you. Even though I've always seen adult patients on the side sort of thing. But now that I'm a chair of family medicine, I'm much more engaged in it. But but nevertheless, I think that the language and the respectfulness is valid. And this is a case I've presented at the National Academy of Medicine. And so it's established. And so Robert is a 48-year-old man. He has obesity. He brings in his 15-year-old daughter, Lauren, for a school physical. Lauren is 5'6", 190 pounds. BMI is 30.7. BMI percentile is 97. So she has obesity. We're not going to discuss those aspects too much, but she's been generally healthy, no problems, good student, normal physical exam except for obesity. BMI percentile has been consistently in that range for 7 years since she was 8 years old. Both her parents and her younger brother, both parents, younger brother who's 10 or 11, also has obesity. So it's the entire family. Nobody has ever raised the issue of her weight with Robert or with his daughter, ever. They're coming in for a school physical. Let's talk about some options. We need to talk about Lauren's weight. And sometimes in ECHO we do pick on people, but I'm just going to ask people to volunteer. What is wrong with that? How about somebody from Total Health and Wellness? Oh. Go ahead. I heard someone.
I was just going to say that when you kind of bring up, we need to talk about Lauren's weight, it almost sounds negative, and almost all of a sudden I would be a defense mode instead of I'm willing to listen about it.
So Sunny made some great comments. This violates every core principle I told you about, basically. Well, at least they're using weight, right? That's the approach. We don't, if you said we need to talk about why Lauren's obesity, that would be, oh my gosh, this 15-year-old girl coming in, you could imagine that would not go well. It violates a lot of principles. We need to talk, okay? First of all, we'll talk next week about why that's wrong. You need to have permission to discuss this very sensitive issue. And secondly, it's very, very directive about this. And it's not engaging Lauren. It's like he's addressing the father and saying, we need to talk about Lauren's weight. There's a 15-year-old girl sitting in the room here who can communicate and probably has her own ideas about it as well. So it's not collaborative in any way. It should come as no surprise to you, Lauren, that your weight puts you in the obese category. Let's discuss this. I'm not even going to talk about how bad that is. Lauren, how interested are you in losing weight? What is wrong with that? Anybody?
It implies that she has a problem with her weight. It
Yeah.
implies that she sees herself as that being a negative attribute, where
Right.
she may be fine with her weight.
Yeah, thank you, Victoria. So, boy, are you making a lot of assumptions. Nobody has discussed the issue of weight with this girl or her father ever. And then the first question you ask, she's doing a school physical for volleyball, is how interested are you in losing weight? Just very, very highly offensive. Is going to put this girl, it's going to, either give you kind of a non-response probably, or shut down, or, or be very, very embarrassed about the issue. Just a terrible way of going through things. Robert, Lauren is very heavy for age. This is something she needs to work on. This is terrible. Using a term that is highly offensive to people with obesity, that's the word heavy. It's completely non-collaborative. She needs to work on it. You're not even talking to the girl. You're talking to the dad and telling her this, and she's listening to this. The problem with any of these openings is that, of course, the patient is going to shut down entirely. So I want you to keep those in mind. We're not going to talk today about the right way to do this, because this is something I've worked on for years and has now been adopted by the National Academy of Medicine. It's called the opening the door approach. You can read about it online, and there are lectures, but we're going to go through that. The reason I spend so much time on that is that this is an area that requires a lot of practice and competency. If you adopt the opening the door approach, and there's different versions of it, Dr. Sharma McMaster has his own version, which is every bit as good. You probably won't go wrong. No matter, you can be a kind of a jerk about this issue if you want, but if you use the opening the door approach, you'll probably establish some rapport and not turn the patient off. And you'll be able to do all the other things that we're all interested in. We're all interested in obstructive sleep apnea and how to manage it. We're all interested in pharmacotherapy and bariatric surgery and all kinds of things. But if you don't open the door correctly, you will not be able to do any of those things. And so we're going to talk about this. So I want you to reflect not so much about what the right approach is, but what the wrong approach is. I want you to use respectful language. I want you to give patients time to do this, allow them to reflect about the goals and suggestions that you have made, and to be as collaborative as possible. So we're going to stop there. We use 25 minutes and see if there are any questions before we go on to our case. Okay, we will turn it back to Shannon with some reminders.
Sure. Okay, you should be receiving a survey in your email inbox. Please complete by tomorrow at 5 p.m. We will see you on October 3rd with communication opening the door. If you haven't chatted your name in the chat box for attendance, please do so. There are quite a few phone numbers on this morning. Several have left already. I will be following up. If you join just via phone, we will be recording attendance as well. So I'll be reaching out to you. Have a great day, everyone. We ended a little early.
Thank you, everyone. We'll see you next week.